My name is Dr. Stephen Liu, a thoracic medical oncologist at Georgetown University. In February 2025, we saw the results from the eNRGy study published in the New England Journal of Medicine. This was a phase 2 study of zenocutuzumab in patients with NRG1 fusion positive cancers. This on the heels of the FDA approval in December 2024 of zenocutuzumab as single agent for previously treated NRG1 fusion positive non-small cell lung cancer or pancreatic cancer. I think an important approval and an important target, but a unique one. When we think of NRG1 fusions, these are pretty rare. They occur in about 0.2%, but they are identified across solid tumors. So there are some rare cancers like a pediatric infantile fibrosarcoma, like a secretory carcinoma of salivary glands that very commonly have NRG1 fusions. And then there are more common cancers that rarely have an NRG1 fusion, but it is important to find these. And this would be a KRAS wild-type pancreatic cancer, a driver-negative non-small cell lung cancer. We see these in colon cancer and breast cancer as well. NRG1 fusions, though, are difficult to detect more so than just their rarity. The NRG1 gene is a very big gene. It is almost entirely intronic, which means if you're using DNA-based next-generation sequencing, it is very easy to miss these fusions because we simply can't tile across the entire gene. Really, to find these, we want to use RNA sequencing, which generally is tissue-based, not liquid-based. So if we are doing next-gen sequencing, looking for rare targets like an NRG1 fusion, if it's DNA-based, you may miss these. It's important to understand if these are there because in lung cancer, which is where my clinical focus is, when an NRG1 fusion is present, these tumors do not respond well to standard treatment. In a retrospective review we published in the Journal of Clinical Oncology, we found patients receiving frontline chemoimmunotherapy with an NRG1 fusion. None of them actually had a response to treatment. Very poor outcomes. This is a tumor that often spreads along airways. Radiographically, it can look a lot like pneumonitis or a ground glass appearance. Very difficult to treat. Symptoms out of proportion of the CT scans. Finally, having a targeted agent here that's effective is long overdue and really fills an important unmet need. If we look at the response rate in the eNRGy study with zenocutuzumab, the response rate was about 30% across tumors. Not as high as we'd like, but still much better than standard treatments in this setting. And the responses we did see were pretty high quality with a response duration on median of almost a year, I think just over 11 months. So these are durable responses. Not all patients do respond. We're still in the process of trying to identify which NRG1 fusions are more likely to respond. How important is fusion partner or fusion variants and breakpoints? Are there other factors that can help predict response? And importantly, are there other drugs that can be effective in this space? But zenocutuzumab, really now, I would consider the best option for patients whose tumors harbor an NRG1 fusion. The drug was very well tolerated. We did see diarrhea as the most common related effect, about 20% or so, but almost entirely grade 1, 2. I think only 1% grade 3, fatigue, nausea, generally pretty low grade, uncommon. This is a well-tolerated drug. It is given through an IV every 2 weeks, and so keep in mind the scheduling component of treatment, but this is an effective drug for a disease that doesn't respond well to standard treatments. But again, only an option if we take the time to find these, and we do need to look a little more closely at how we're running this biomarker testing. RNA sequencing, really the way to go.